Steve McCarthy, welcome back to Freedom Is Not Free. Unfortunately, unlike what we see in war movies, battlefields are noisy, dirty, dangerous places. When people become casualties, they don't calmly lie on the ground. Too often they are in severe pain and need immediate attention. My next guest, retired Navy Captain George Frankhouser, spent his career in the Navy helping these casualties. George, pleasure to have you here. First and foremost, thank you for your service.
Thank you, sir.
I guess the obvious first question, George, would be why the Navy? Why choose to practice medicine in the military in general?
That's a very easy answer. In 1959, I was approaching my senior year of medical school at the University of Virginia, and the money at home was about to run out. I was offered a scholarship for the senior year. It's called the Senior Medical Student Program. And they put you on active duty if you were selected for that year as an ensign with no longevity. But it did bring some money in. In return for that, that was when the draft was active. And so in return for that, I agreed to give them an extra year beyond the 2-year selective service requirement.
So 3 years worth of service, they paid you last year of med school.
In effect, yes.
Okay. When you finish med school, of course, traditionally the doctors have any number of programs they have to complete. Did the Navy provide all that training to you when you went on active duty?
Well, in 1960, the internships that were available were basically zero pay for a good internship in the civilian world. The Navy had excellent internships, and the promotion was kind of weird. The day I graduated, they changed me from reserve to regular and made me a lieutenant JG, and 2 weeks later I was promoted to lieutenant. They skipped that JG part now. And I was accepted for the what's called a rotating internship at the Naval Hospital, Pensacola. They don't have those anymore, which is a real shame. It's you rotate through the different services: internal medicine, surgery, orthopedics, pediatrics, OBGYN. I delivered about 200 babies that year. And it's a shame they don't have that anymore because they start specialization far too early now.
So you were exposed to a number of specialties, in fact, settled on general surgery.
Yes, I admired the general surgeons that I worked with, and I have rather a mathematical mind, and general surgery is about as close to mathematics as you can get in the practice of medicine. You have a definite problem, you certainly have a definite approach to it if you operate on somebody, and you usually get an answer. Diametrically opposed is psychiatry.
Now, briefly, because the training for a surgeon is vast and comprehensive, but at what point do you feel like, as a surgeon, as a military surgeon, you were fully prepared to put that scalpel in your hand and cut into another human being?
Well, you sneak into that. When I was in medical school, I used to hang around the emergency room, and the interns let me do a lot of work there, and so I was quite comfortable with working with my hands and sewing people up and that type of thing. The point of cutting somebody open is over-dramatized on TV. I mean, I used to tell my residents when I was teaching that making the incision and closing the incision are necessary evils. They're not the operation. They're part of the operation, but the real operation is what happens when you get inside.
Now, as a serving naval officer and as a doctor, did you find that those two roles sometimes collided, that your medical opinion was X or the way you wanted to proceed was Y, but the naval responsibilities interfered with those decisions?
I only saw military rank enter into my practice one time in 20 years. And that was a time when I was with the Marines from 1961 to 1962. And it was a situation involving a patient that had 18 years active duty as a corpsman, second class hospital corpsman, who had been a second class for 12 years. And he was an admitted alcoholic. He was anemic. He couldn't do a single push-up. And I was going to be at sea with him and have to find him fit for duty to ship over. And I knew I wasn't going to be able to do that, so I called him in my office and examined him. Said, what you need is a medical board of disability and get you out of the Navy. He said, my golly, I've been trying to get that for 5 years. Will you do that for me? So I can't see a problem, so sent him over to the hospital to get his board, and they sent him right back to me and said all he needs is some iron and vitamins. And so I went up my medical chain of command to the division surgeon, and he physically patted me on the shoulder and said, that's all right, doctor, if you don't find him fit for duty, you're covered, and no problem. That wasn't satisfactory, and so I went up my military chain of command to my battalion commander and explained to him what the situation was. And his name was Richard Mample. He was the military advisor on that movie, The D.I., with Jack Webb. He'd just come from Hollywood, very dramatic. So he called the doctor I'd talked to at the hospital, and I never saw a man get so red in my life. He got the same stuff I'd gotten. And finally he just said, I don't give a damn what you say at that hospital. This man will not be shipped over in my battalion unless my battalion surgeon tells me he's fit. Hung up the phone. Well, 2 days later, we hauled that man out of the shower dead. And I didn't have any more trouble getting what I wanted in that battalion.
You touched on that you actually, I believe, did a deployment with the Marines into the Med. The majority of your career, you served with naval units, still supporting the Marines, but not as directly. What was your impression of Marines versus Navy, and did you ever serve with Marine medical officers?
Well, all of the medical officers in the Marine Corps are Navy.
That's right.
As are all the corpsmen and the chaplains and the dentists, and the medical service corps officers. So we were all of the same cloth. I told when I left the 2nd Marine Division in 1962 to start my surgical training, I got an appointment to see the commanding general. And over his secretary's objections, I was a lieutenant at the time in the Navy, and she said only field grade officers pay their respects when they're leaving. And I said, well, that's all well and good, but I still want to see him. And I ran down there on a 5-minute call notice to see him. He was sitting behind his desk you could land a plane on, a lot of flags. And he was not welcoming at all. And I said, sir, I'm Dr. Frankhouser from 1-6. He said, yeah, I know who you are. And I said, well, Sir, I've been with the 2nd Marine Division now for a year. Yeah, I know all that. And so I said, well, sir, I've served under 2 colonels, and I know it's not right for a junior to report on a senior, but these 2 colonels have backed me up when they didn't know whether I was right or wrong. And it just meant the world to me. Of course, I was right in what they were backing me up on. But I felt I owed it to them to let you know, because you're the only man on the base that has jurisdiction over both of them. And he said, oh my God, Doc. He said, sit down and have a seat. Would you like a cup of coffee? And we talked for about 45 minutes and about Colonel Stan Davis and Dick Mample.
It sounds like he had the impression you were going to come in and tell him what was wrong with his command.
Exactly.
You also served in various general hospitals within the states, overseas, afloat in the Med. We're going to talk about your Vietnam service separately. Generally, what were the challenges serving overseas versus within CONUS itself? Were facilities equitable in both places, or were there challenges when you were overseas or afloat?
As far as the hospital ship goes, we were better equipped than most of the hospitals in the United States. For instance, there were only 6 frozen blood banks in the world at that time, and we had one of them. The current hospital ships are as well equipped as any hospital in the United States. I did run into an interesting situation on a different cruise later on after I was a surgeon. I made a cruise across the Pacific and back with the midshipmen. I forget the year, maybe 1974 or so. And in the middle of the South China Sea, I had a fellow come down with a bleeding ulcer. And it's not a real problem. You've got a walking blood bank on a ship. And my corpsman came to me that was supposed to be my blood technician, and he said that he had forgotten to bring the anti-human globulins, so he couldn't give me a complete cross-match. So I said, well, let's get some O-negative blood up then, and we transfused the guy, and right after I got that word, the messenger came from the skipper of the ship, and he said, Captain's compliments, sir. He wanted me to advise you we're going to be in typhoon conditions within 12 hours. Now, you don't get that on a land-based hospital. And so, and I had to manage the anesthesia and the operation. I operated on him, and all went well.
Within a typhoon?
No, before the typhoon.
I mentioned that we were going to talk about Vietnam separately. You were on a hospital ship off of Southeast Asia. Briefly, could you take us through what your average day as a surgeon on that ship was like?
Well, I was on the hospital ship Sanctuary, AH-17, and we were stationed in the I-Corps region. We went up and down the coast on a scheduled basis, mainly from Chu at the south to Da Nang to Phu Bai and Dong Ha. And every so often there would be an insertion ashore, like there was one at Tom Key, that they came out and briefed us the night before and told us what was going to happen, and they predicted on that one we would get in the neighborhood of 220 casualties, and that's what we got.
Now, how many general surgeons were there on that ship?
There were 5 of us. Two of us were board certified, and one of our chief of surgery was also a thoracic surgeon. And then we had most specialties represented. We had a urologist, we had an orthopedist, Carl Brighton was our orthopedist. He went on to become the chairman of the Department of Orthopedic Surgery at the University of Pennsylvania. Fred Jackson was our neurosurgeon. We had an ENT surgeon.
I interrupted you because when you just casually mentioned we're going to get 220 casualties. Now that's 220 cases that need medical attention of some type, probably a lot of surgeries. How did you prioritize those surgeries? How did you deal with the stress of those surgeries day after day, or in these times when you had a lot of casualties waiting and you've got to give your full attention to each case? How do you deal with that?
That's where triage comes in. It's a French word meaning to sort. The patients would arrive, the vast majority of our patients would arrive by helicopter. The CH-34s would come in carrying maybe 4 patients. The 46s would carry 8 or 10. And the difference between our hospital ship, the Sanctuary, and the Repose, which was already on station when we got there, the Repose could not land the CH-53, the big boy.
Right.
And they could bring 22 litters, so we hated to see that one coming. But the patients would be offloaded at the helicopter flight deck on the stern of the ship and brought down a ramp to our triage area. And the triage area is very cramped. We did have a status board in there that we kept track of where we had sent the patients that day, so we'd spread load them through the ship, and we kept track of upper bunks and lower bunks available. We had over 700 beds, but some of them really weren't usable, 6 deep or something like that. They would be okay for medical type patients, and we had a lot of those too, the malarias and everything that internal medicine people work with. But we had, from a surgical standpoint, we had to keep our patients down. And incidentally, we had acquired, before we left the States, we acquired some Hill-Rom beds, which are the Cadillac of hospital beds, and put those into our ICU. So our intensive care unit had standard hospital beds, and we welded them to the deck. We also got some beautiful Hill-Rom gurneys and found that they wouldn't fit into our elevators.
Oh. But you were dealing with catastrophic injuries in most cases, where the combat injuries, bullet wounds, frag wounds from grenades, RPGs. I'm going to guess that prior to your deployment, you had not seen gunshot wounds and those kind of injuries before. And again, how did you train yourself? You had the skill and the knowledge. How did you train yourself emotionally to just detach and get the job done?
Well, the emotional aspect of it really wasn't a problem, but you're very perceptive that the wounds of combat are quite different than the civilian ones. When you get into a discussion of wound ballistics, you draw the line at 1,000 feet per second. Below that is a low velocity wound. Above that is a high velocity wound. So a knife, for instance, is an ultimate low velocity wound. It injures that which it cuts. A .45 caliber bullet exits the muzzle at 810 feet per second, and so it's got to be a big slug. It's a low velocity wound. But you go up to an M16 with 2,600 feet per second, 3,600 feet, and the energy of the missile is what does the damage. And E equals mv squared, so it's the square of the velocity that counts. And so a high velocity wound, or you get to the multiple fragment wounds of mines, mortars, booby traps, grenades, artillery shells, bombs, all that stuff. There are multiple velocity wounds, different varying types, and so you have to know about that. I wrote a paper out of Vietnam. It was entitled "Avoidable Complications in Combat Casualties," and it's documented with photographs. And I presented the paper at the Association of Military Surgeons meeting in Tokyo on the way home, actually. I think it was the only negative paper in that entire 3-day conference. And it had to be said, though, that the Navy was making some bad mistakes. For instance, the hospital at NSA Da Nang, the entire personnel might be turned over in a week. Therefore, you would relearn to make the same mistakes every year, annually. And so when I got home, I was at Camp Lejeune after return, and Porter Collier was an orthopedic doctor who was ashore in Fubai. And he and I put together a little dog and pony show. And we gave it probably 30, 40 times to anybody that had orders to Vietnam in the medical field. Corpsmen, doctors, didn't make a difference. He showed what the situation was ashore. I showed what it was on the ship. And then we went into the actual treatment of casualties. And one time we gave that presentation to 2 surgeons, only 2, on our day off. And both of them were from Texas. And one of them, at the end of our presentation, looked at Dr. Collier and he said, you know, George Frankhouser is full of you know what. He said, I've taken care of gunshot wounds and I know what to do for them. And it's the only time in my life I ever saw a Porter Collier get mad. He went right into orbit. He said, Doctor, you have not seen the kind of stuff you're going to see in Vietnam. And every word that has come out of George Frankhouser's mouth is gospel truth. You either learn it here today or you learn it over there and kill people doing it. So I think it's quite different.
I think it's interesting when he said, I've treated gunshot wounds, probably meaning one person, one gunshot wound.
Well, there's probably a handgun. Now, in truth, the modern era has semi-automatic weapons and high-velocity wounds that the police are having to deal with all the time now. And when you look at some of the slides I have of what a high-velocity wound will do, one bullet. For instance, one of my patients was on a PBR, Patrol Boat River, and he was standing in the doorway as they approached a sampan that was, it was about a mile or so from our ship. And the guy on the sampan shot him with a rifle. That's a high velocity wound. And the wound of entrance in his abdomen, insignificant. The wound of exit in his back, they make a big deal about that. You can hardly tell it from the wound of entrance. It's almost insignificant. But it took 26 pints of blood to get him onto the operating table. All 26 pints were in his belly when I opened him up. So the way a surgeon handles that, you dive for the aorta and put your fist on the aorta and cut off the blood flow, and then you go searching, suck it all out, and then go searching for where it came from.
And really, with all the training in the world, until you see wounds of that nature and have to deal with them, it's a whole different realm of military surgery.
Indeed it is.
Of all the cases that you handled, let me challenge you, is there one case that you were particularly proud of, or that the first time you looked at him, you said, this does not look good, and you were able to get him through?
Well, that particular patient I just mentioned,
okay.
He contacted me in 1981, 14 years later. And he said it was at Thanksgiving time. He said they were sitting around Thanksgiving dinner table, and he thought he'd call me and tell me that he was doing well and thank me for taking care of him. And the photographs I have of his wound, I have intraoperative photographs as well as the wounds, and pretty dramatic. And the patients in that era, there were a lot of things that advances made in medicine, going all the way back to the Civil War, for instance.
Sure.
In the Civil War, amputations were quite common, and speed was essential. Then you get to the First World War, and we found that in the First World War that if you sewed a wound up, you had a very high chance of it turning to gangrene, getting infected and gangrenous. And so we started leaving them open. And so the initial treatment of a lot of these wounds was to debride them, minimal skin, maximal subcutaneous tissue, muscle back to bleeding, contracting muscle, stop the bleeding, wash the thing out, and pack it open. And then several days later, you take the patient back and do a delayed closure over a drain. And that was the gold standard, if you will. And so there were very few days, even when we weren't receiving fresh casualties, there were very few days we didn't have delayed closures to do or delayed bleeding happening or something like that. And so we also found in the Second World War and going into Vietnam that many chest wounds did not require an open thoracotomy. You could get a chest tube in, reinflate the lung, and a lot of times the bleeding, most of the times actually, the bleeding would stop, the air leak would stop, and you wouldn't have to do a thoracotomy. Now, every so often you'd have one that you had to open, but right. Most times not. I mean, we did thoracotomies, we had some screwy wounds too. I mean, really weird. There's one where one of my first patients actually, the bullet wound is in the left deltoid, and the man came in complaining of abdominal pain. So we take x-rays, there's a bullet in his left upper quadrant of his abdomen, it looks like. His chest is clear, and opened his abdomen, couldn't find anything. And sewed him up. It took 35 x-rays to show that that bullet had gone into his chest cavity without injuring the lung and just dropped by gravity in his chest cavity. Or there's one where it was a neck wound, it wasn't bleeding. And on x-ray, the bullet's in the heart. And we put him on cardiopulmonary bypass, which we had, and opened his heart. It's got to be in the right side of his heart to get there with no bleeding up here. It wasn't in the right side of his heart. It was in the left side of his heart. Now, how it got there, we don't know to this day. I mean, weird stuff happens.
So it's fair to say that in a year of surgery off of Vietnam, that you saw more than some surgeons would see in a career, in a lifetime.
It's my training as a surgeon in the Navy, I've said many times, was probably the best training anywhere in the world at that day, at that time. And it goes to the fact that the draft was in place. With the draft, if you were in surgical training in a civilian hospital and your number came up, you got zapped. And so a man with 3 years of training out of a 4 or 5 year program couldn't go in as a surgeon. He wasn't a surgeon yet. So he's wasted. So Senator Berry put through a plan that was named after him that said that if your number came up in training, you could be deferred until you finished your training. But you had to agree that at that time you would go in no argument, no additional time incurred, but you would go in then as a specialist. So the Navy took their top finishing draftees, if you will, in the Berry Plan and put them into the teaching hospitals. So my teaching staff, when I was in San Diego, and I trained in both San Diego and Philadelphia, but my teaching staff came from every major institution in the United States. I mean, I had a staff man from everywhere from the Mayo Clinic to Hopkins to, I don't know, name it. I had somebody from there. And our conferences were dynamite, and our numbers were staggering. I mean, I did over 750 cases as a first-year resident. The average civilian resident in 4 or 5 years of training would do 750 cases in 4 years. And that doesn't count the ones I did as assistant, or the 200 fracture reductions I did, or the 1,000 proctos I did. I mean, the numbers are staggering. And then in Philadelphia, we had the staff of the University of Pennsylvania come as consultants, including at Children's Hospital was C. Everett Koop, who went on to become the
Surgeon General.
Surgeon General of the United States.
Well, obviously, it comes across that you're not only very proud of your accomplishments, but of military medicine in general, that it was a combination of top-notch training, vast experience, and probably cutting-edge methods to handle things. I did want to take a couple of minutes, though, and talk about your experiences with returning Vietnam POWs. How did you get involved in that, George?
Well, in 1973, I was on the teaching staff at the Naval Regional Medical Center in San Diego, and I was in charge of the sick officers' quarters surgery, the VIP ward, if you will. When we found out that President Nixon had negotiated the release of the POWs from Hanoi, I was told that they were going to basically shut down my ward. I was going to be out of business. And so I asked my team if they would like to volunteer to be in on this POW thing. We had no idea what we were going to be getting into. We'd all seen the Manchurian Candidate, and we didn't know whether it was going to be that or what, you know. And so we did volunteer, and I was the senior surgeon for the returning POWs through San Diego. We had about 55. And I was also the primary care doctor for 5 or 6. And some of my patients were, astounding patients. Well, Jim Stockdale, who went on to become a Medal of Honor recipient, right, and ran for vice president with Perot. He was one of my patients. And Ernie Brace, the longest held civilian prisoner of war. He was flying with Air America for the CIA when he was captured. And he was kept out in a cage in the jungle for about 3 years in isolation, escaped 3 times, buried alive for a week. I mean, incredible stories. And so it was...
And you were dealing basically in some cases with injuries that had happened several years before and never been fully treated, plus the psychological impact of imprisonment, like the man you mentioned, long-term isolation. How did you fit their physical and mental care together?
Well, we had a physical examination that we did on them and a medical debrief. We called it the phone book physical. And it is about 490 pages of debrief for each man. Emotionally, these guys were the most stable people I knew. As a matter of fact, 3 or 4 months after I met Ernie Brace, I had to go to sea on that midshipman's cruise for a couple months. And I told my wife, if anything screwy happens while I'm gone, call Ernie. He'll know what to do.
Really?
I mean, even the psychological issues were nothing with them. They were solid people. I mean, unbelievably solid. And I met Doug Hegdahl, who was ordered to accept an early release if offered. And he was an enlisted man who had fallen overboard and been captured by the North Vietnamese. They thought that he was a spy, and he ended up in the Hanoi Hilton, though. And he tried to act the idiot. So he put his glasses, at a weird angle like that, and he walked around and acted the idiot part. And he had a little more freedom than some of the other guys, but he became one of their information centers. And anything you can see or hear, you can do in code. So he became like their local newspaper when he was sweeping in the courtyard. And fascinating stories. He memorized over 400 names and status reports. And that's when Stockdale ordered him to accept early release if possible. And the bottom line on that story was that he and another one of the POWs were put into a cell, and the word was that one of the two would be released early, and his cellmate said he tried to learn the list, no poor nutrition, no pencil, no paper, he just couldn't do it. And so he said, Doug, you're the one that's got to get out of here. And so he went over and beat on the door, and when the turnkey opened it, he slugged the turnkey. And so Douglas Hegdahl was the one that got out. That man got an additional 3 years of confinement and ultimately a divorce. His wife said that he could have come home early to her, and he didn't.
From the time that the POWs came home, how long were they with you before they were all released and sent to units or sent back to civilian life?
It varied. There was an awful lot of stuff that went on back then. They had an agreement that all of them would be subjected to a general press interview before any individual contracts were made. There were a lot of benefits laid on them by various companies. For instance, I think the Ford Motor Company gave them each a car for a year. Things like that these things were accepted with the understanding they would not be used as promotional value.
Right.
And, a week in Hawaii or whatever. And so I remember I fixed a couple of hernias that were there, and guys were on the beach in Hawaii a week later, And one fellow named, his name is Cole Black, and he's now passed on, unfortunately, as has Ernie Brace, the one I mentioned earlier. But
well, we sometimes forget Vietnam. Saigon fell 41 years ago. We're all beginning to get up in age.
But it was such an intense experience that it seemed like it was yesterday.
Yeah.
And I was talking with my brother the other day, and he was asking if in preparation for this meeting today, did it bother me? And yes, it does.
Well, there's a comradeship of serving in the military. There is a whole different kind of comradeship when you serve in combat, and it does bring back memories very, very quickly. In a long and distinguished naval career, culminating as a captain in the Navy and as a surgeon with vast experience, what's the one thing you're most proud of your military service?
I think for the military service, there are maybe 3 or 4 things that I'm really proud of. One, of course, is Vietnam, that experience. And then the POW experience. that was very, very rewarding, and I'm still in touch with some of the families of my POW patients. This 45 years later or whatever. And then I ended up quite by accident writing a disaster plan for the Naval Regional Medical Center in San Diego. And I threw one out that was over 600 pages long, and wrote one that was in 19 pages, and it worked. And then because of that, when President Nixon came to town, our CO went into orbit and said, we don't have anything written down for what to do if something happens to the president while he's here. And I ended up having to write something directed at our hospital right then, but ultimately it ended up being the mobile medical support plan used by the White House. That's still used because of the way it's written.
That's kind of a legacy and a testament, both professionally and I probably can't think of the correct word, but that has to give you some pride every time you see the president, practically.
Oh yeah, I was in direct support for President Nixon, President Ford when he came to town. I got to ride in his motorcade, as a matter of fact, and met him at the ladder to get on to Air Force One. And then I was in the basement of the Capitol when Jimmy Carter was giving his State of the Union address. And then after I got out of the Navy, I was still on a list of surgical providers for the White House. And with President Reagan living right up the hill from us in the Center Nest Valley, I was in the ambulance when he came down to vote with a Secret Service agent and all that, so it was very interesting.
And very rewarding. Final question. If I say patriotism to you, George, what does that mean to you?
Oh, I think love of country and what it stands for, and willing to sacrifice something for it.
Well, certainly it comes through loud and clear that you have a lot of pride in your professional accomplishments in your service, and we're certainly proud of you, and thank you very much for spending some time with us. Thank you for your service. It's been a pleasure and an honor.
Thank you for having me.
For SCA TV, I'm Steve McCarthy.